Welcome to Medically Speaking, a podcast for your good health from the University of Maryland Medical Center and the University of Maryland School of Medicine in Baltimore.
An estimated 80% of Americans experience back pain at some point in their lives. Back pain is one of the most common medical problems in the U.S. and a major reason for people to miss work. What causes most back pain? What can we do to prevent it? This is Karen Warmkessel, and I'm here today with Dr. Daniel Gelb, an orthopedic surgeon at the University of Maryland Medical Center who specializes in treating spine disorders. Dr. Gelb is co-director of the University of Maryland Spine Center and associate professor of orthopedics at the University of Maryland School of Medicine. Dr. Gelb, thank you for joining us today.
It's my pleasure to be here.
Let me go back to my earlier question. It seems that many people have problems with their backs, especially as they get older. Why is that? What causes most back pain?
There's multiple reasons why people experience back pain, and each of us may have one or several of those causes in play at any given time. We know that back pain is exceedingly common. It is probably caused to some extent by the normal aging process that occurs in the spine in combination with the particular activities we participate in during the day and some of the poor postures and unusual activities that may put stress on the back that we're forced to do by virtue of our occupation or recreational activities.
If you have back pain, how do you know if it's caused by a strained muscle or something more serious, such as a disc problem?
Most back pain that occurs in the general population is self-limited in duration and relatively benign. People will have an episode. It may last for a few days or even a few weeks, but the natural history of most of that pain is that it will go away spontaneously, and it is only necessary to try to keep comfortable while we wait for the pain to resolve. And it's really not terribly important to us whether that pain is caused by a muscle strain or a disc problem or some other cause, as long as it is going to resolve on its own without requiring any type of interventional treatment. As we age, all of us develop changes in the discs of our spine. That's a natural aging process. In fact, if you take patients who are totally asymptomatic in relation to their back, say patients who come in with a problem, say gallbladder disease, and you ask them, have you ever had a back problem? And many of them will say, no, never. And if you go ahead and get an MRI scan of those patients, their discs will show the same changes of the patients who have back pain problems who come to see us. So the changes we see on, say, an MRI scan are very nonspecific, and it's only when the patient's pain pattern is persistent and correlates with those changes that we can make an association.
How long do I try to tough it out on my own before I decide that I really need to see a professional?
Well, as I said, most back pain is self-limited and will resolve in a week or two. I think you need to balance the intensity of your symptoms and the type of symptoms you're having with the chronicity. So if you have back pain that's been present for a day or two, is fairly well relieved with, say, Tylenol or over-the-counter ibuprofen, that when you lay down is significantly relieved, so at rest you have good pain relief. If there's no neurologic component, say pain going down a leg or numbness in your foot or weakness in your leg, certainly the likelihood of that being a serious problem is fairly small. On the other hand, if you are having weakness in your leg or numbness in your leg, or the pain is not relieved with laying down at rest or with simple medications, if there's any sense that you might have an infection, fevers, chills, those are warning signs that this may be a more serious problem and needs earlier investigation.
And if a patient comes to your office, then how do you actually go about diagnosing what the problem is? Let's say someone has been experiencing this sort of bad pain and it's not relieved by Tylenol. They come in, and do you do MRIs? How do you diagnose what the problem is?
The best thing that we can do to make a good diagnosis is talk to the patient and get an accurate history. The more specific people can be when they come to see me and tell me exactly when it hurts, exactly what activities seem to make the pain worse, what helps it, where it is, what time of day it occurs, whether it is involving a leg or an arm, whether it radiates, whether there's other associated symptoms, helps me to make my diagnosis more than anything else. Likewise, physical examination, a good, solid reflex testing, motor testing, manual palpation of the spine all play a role in helping us get some idea as to why that patient is having such persistent severe pain. And the last piece of the puzzle is that imaging. First, we always get simple x-rays. They're a very cheap and effective test. It allows us to see the spine in a position of function. If we get an MRI or a CAT scan, that patient's always laying down, and we don't know what the spine looks like when the patient's standing up, and that's really when most people have their pain. So that x-ray is an important piece to us, and allows us to see whether there's any misalignment of the vertebra or spinal deformity, fractures. Tumors are often seen on x-ray. Following that, if we can't make a good diagnosis, we will go on to advanced imaging studies. MRI scan is certainly the most commonly used test to help us evaluate the discs and the health of the discs and whether there's a herniation and maybe some impingement on a nerve causing sciatica. Mm-hmm. But you need the whole picture. You need to have a complete evaluation. It doesn't do any good for someone to send me an MRI scan to look at without a clinical history because it's too nonspecific.
Okay. When does a patient have to have surgery?
Surgery is reserved generally for patients who fail conservative treatment. As I said, most of these problems are not dangerous. Even a herniated disc causing sciatica is likely to resolve on its own within 6 to 10 weeks. So that if we can keep a patient comfortable, if we can put them through physical therapy, maybe give them a steroid injection, get them on the correct pain medications, if their pain resolves within a few weeks to a few months, we feel that that's an acceptable treatment algorithm. Some patients come to us after 3 or 4 months and their pain is just not getting better. Their pain is significantly interfering with their life, their ability to enjoy their quality of life, their ability to complete their job activities. And those patients often, if we can identify a specific cause of their pain so that we know exactly what we're treating surgically, we'll offer those patients surgery. Additionally, you do see patients occasionally who develop significant neurologic deficits, a dropped foot, real weakness in their leg, and those patients may be candidates for early surgery in order to make sure that those deficits don't get worse or try to improve on those deficits.
What is the most common spine surgery?
I don't know the actual statistics in the United States, but we can break the problems that we see in terms of low back problems really into two major categories. We have patients who have pain that's related to a pinched nerve or extrinsic neurologic compression. So you may have a herniated disc, and that portion of that disc that's been herniated is pinching a nerve, causing sciatica. Or you may have what's called degenerative lumbar stenosis, where the complex of arthritis that occurs as we age begins to narrow the spinal canal. So for patients with some kind of nerve compression, we offer them a decompressive procedure. The old standby is a laminectomy, but now we do things with a microscope. We do microdiscectomy or some type of minimally invasive procedure to make sure those nerves are no longer compressed. The other general category we see is patients who have some type of arthritic condition. They've developed enough degeneration, usually in their disc, that they have persistent back pain as opposed to leg pain. And for those patients, we generally will offer a spinal fusion as an alternative. If the arthritis is limited to one segment in their spine, so we can do a limited fusion, that's a fairly good operation for someone who can't be managed any other way. These days, there is the possibility of doing an artificial disc replacement for a younger patient who has significant pain that limits their activity, and their arthritis is limited to one bad disc. We can replace that disc with a prosthetic one, with one made of metal and plastic, and that is an alternative to fusion that has been coming up and more popular in the last couple of years. We see people who have spinal deformity who have scoliosis or a condition spondylolisthesis, which means one vertebra is slipped in relation to another. And for those patients, we will offer also a spinal fusion. And many times we do a combination of procedures. Patients have more than one diagnosis, so we need to do both a decompression and a fusion in order to treat all the pathology to make sure we've taken care of all the possible pain generators.
So if it is related to aging, is there any way that people can prevent getting some of these problems?
Well, as you've mentioned, 80% of Americans suffer back pain at some point in their life, so it's very difficult to completely avoid this problem at all. However, only about 5 to 15% of Americans develop persistent problems that are debilitating. So for most of us, this is an occasional problem, and we weather the storm, and we get back to our usual activities. There are certain things we know are associated with an increased incidence of back pain, and some things that are known to help people who have back pain experience less. So, for instance, there's no question that smoking, cigarette smoking, is associated with an increase in disc degeneration and back pain. So for all of our patients, we counsel them that they should attempt to quit smoking if possible. We know that patients who are more aerobically fit and who exercise regularly tend to experience less back pain than patients who are sedentary. So we encourage all of our patients to become involved in a regular exercise program to help strengthen their back muscles and keep themselves fit and lose weight, because we feel all these things are important in preventing back pain episodes. There are certain ways of using your back, and if you are someone who is doing a lot of lifting and bending, we know that proper body mechanics plays a big role in protecting that back from injury. So we encourage patients to go to the physical therapist to learn how to use body mechanics properly, to bend their knees when they lift, to keep their back straight, to use their abdominal muscles to help brace their spine when they lift objects or participate in vigorous activities. All these things can help prevent occurrences of back pain, but not totally eliminate them.
So those are pretty good tips for people to maintain good back health, I think. Thank you very much, Dr. Gelb, for being with us today. This is Karen Warmkessel, and I've been speaking with Dr. Daniel Gelb, an orthopedic surgeon who is co-director of the University of Maryland Spine Center and an associate professor of orthopedics at the University of Maryland School of Medicine. Thank you for joining us today.
Thank you.
You've been listening to Medically Speaking, a podcast produced for your good health from the University of Maryland Medical Center and the University of Maryland School of Medicine in Baltimore. This podcast is meant to provide general information, not to replace your consultation with a personal physician about your particular health concerns. To reach a University of Maryland physician, call 800-492-5538. That's 800-492-5538. Or visit our website at www.umm.edu. Again, that address is www.umm.edu. Thanks for listening. We hope you'll join us for other Medically Speaking podcasts.